This is SSN.
Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. On our last episode, we talked about how the Chronic Pain Center of Excellence and the research process they are doing is helping to improve chronic pain treatments. They got some very interesting research projects underway that will help with chronic pain. So if you missed this episode, you can listen to it on our Spotify and Apple feeds. Now, this is our last episode of Season 5, and I want to thank our listening audience from Canada, the US, Europe, UK, and Australia for the great support and feedback on the topics for this program. So please keep your comments coming and what kind of topics you'd like us to talk about, and I'll try to find the best experts to discuss those topics. Season 6 is going to have some great upcoming subjects. We're going to talk about muscle loss and supplements. We're going to talk about how to gain muscle, inflammatory burden, and many more. So if you want to get notifications for the most recent episodes, subscribe to the podcast. In Season 4, we had Dr. Max Sun on the show, and he gave us an overview of arthritis and how it impacts many people. This topic was well received, and we've had many requests from the audience for more information about arthritis. So today, I'm joined again by Dr. Max Sun, professor at UBC and a pain specialist, to talk about inflammatory arthritis. Max, welcome back to the show.
Thank you, Tom. It's good to be back.
So maybe let's start with, and we talked a lot about arthritis in the last show. So what's inflammatory arthritis?
That's a very good question. On our last show, we mainly talked about osteoarthritis. Now, for listeners here, there's over 100 types of different arthritis. And not all of them are inflammatory, not all of them are osteo. So as a rheumatologist, the ones that we deal with mostly are a subset of arthritis called inflammatory arthritis. And I think that does cause a little bit of confusion to not just listeners, but doctors as well. Because what's our definition of inflammatory? Everything can have an inflammatory component. So from my perspective and from a rheumatologist's perspective, when we talk about inflammatory arthritis, we're talking about a very specific subset of autoimmune arthritis that's caused by the inflammation of your own body's immune system against your joints. And those include many different types, but the main ones are rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and all those sub-varieties thereof. So when we look at inflammatory arthritis, our definition is you have your autoimmune system, your immune system, which is quote unquote overstimulated. And there's many different causes. The specific cause is still being elucidated, but these immune cells then start to attack your own joints, and they can cause joint pain that can be similar to osteo, but to a much higher degree. And the main issue with this type of inflammatory arthritis is that this can be treated with systemic medications and needs to be treated with systemic medications as soon as possible to prevent long-term permanent damage and to prevent other long-term chronic sequelae or effects from uncontrolled inflammation.
You talked about osteoarthritis, and if I remember this correctly from the last show, it's more of a wear and tear kind of arthritis that we're receiving. So this is an inflammatory arthritis. So when someone's struggling with chronic pain and they have inflammation, is this part of inflammatory arthritis? Does it lead to inflammatory arthritis, or is it completely different if we're talking about inflammation, chronic pain?
That's a very good question. And that's actually a very, very complicated question to answer because people's definition of inflammation is very different. So in a pure rheumatological sense of inflammatory arthritis, it's a very specific, detectable type of joint inflammation that's actually so severe that it causes joint swelling, more so than what you would see with osteoarthritis. It causes bone loss, it causes bone damage, which is opposite of what you see with osteoarthritis, where you actually have new bone formation to try and overcome the wear and tear of the cartilage. In inflammatory arthritis, the inflammation of the synovial membrane that surrounds the joint becomes really inflamed and thickened, and it actually eats into the bone, and you actually have bone loss from inflammatory arthritis. So from a rheumatological definition of inflammatory arthritis, it is actually a different entity compared to chronic pain that has some neurogenic inflammation, or when people use the term inflammation very loosely to describe the type of pain they're feeling. So it's a very different phenomenon. So I think from our point of view, from a rheumatology point of view, we see a lot of people who come to see us with joint pain here and there. And the main question is this osteoarthritis or is this inflammatory arthritis? And so some of the things that I look for when I see these kind of patients, especially those with pain in the hands, because certain pain in the hands can be due to osteo and certain pain can be due to inflammatory arthritis. There are certain key points that we look for. Okay. So number one, for people with osteoarthritis, what they generally feel is that the bones become a little bit bigger. They have new bone formation because of the loss of cartilage. The body wants to compensate and they produce bone in other areas to compensate for the loss of cartilage. So you have bony enlargement. Okay. Whereas in rheumatoid arthritis, it's not so much the bones becoming bigger, but the entire joint becomes swollen with more fluid. So when you feel the joint in inflammatory arthritis, it feels like a grape. It feels like a grape and you can squeeze it because you can feel the fluid inside. Whereas in osteoarthritis, it feels like a walnut. It feels bony. You feel protrusions, but there's not that much swelling. Okay. The other thing that we look for on history is, generally speaking, with osteoarthritis, people do tend to feel stiffness in the morning, but the stiffness in the morning lasts, 15, 30 minutes, usually within an hour. Whereas in rheumatoid arthritis, and this is not 100% rule, but general rule of thumb, in rheumatoid arthritis, usually people have stiffness that will last 1, 2, 3 hours. It takes them at least more than an hour of movement to feel more loose. Another factor is nighttime pain. So in osteoarthritis, some people will say, when I move my hands at night, when I'm sleeping, when I move the wrong way, it hurts, I wake up. And that's expected in some cases. But in rheumatoid arthritis, most of the time when people have severe rheumatoid, they will say, doc, I go to sleep in the morning and I feel quite good. And I'm able to sleep. But always around 2, 3 a.m., the stiffness just wakes me up. I have to get up. I have to move around for about 30 minutes to an hour to feel less stiff. And then I go back to bed and I sleep until the morning and I wake up and I still have stiffness. That takes about 1, 2, or even 3 hours to feel better. And so those are some of the key differences that I look for when I assess people between osteoarthritis versus inflammatory arthritis.
That's interesting too, because when you're talking about inflammatory arthritis and it's attacking a joint, so you got more of a fluid buildup versus a harder joint. Because it's affecting the immune system, does it then also spread to other joints, or are you finding it more localized to certain parts of the body?
Yeah, it depends on the type of inflammatory arthritis. Different subtypes affect different joints. In general, the most common ones we see, which is rheumatoid arthritis, it mainly affects the joints in the middle of the finger. So we call them the PIP joints. It mainly affects the knuckles. It affects the wrists, elbows, shoulders. It can affect the hips, knees, and ankles. And it can affect the balls of the feet. That's usually what's affected in rheumatoid arthritis. Rheumatoid arthritis, usually it's symmetrical, meaning that what's affected on the right side joints are similarly affected on the left side joints, mirror each other. Okay. In contrast, with osteoarthritis mainly affects more load-bearing joints, knees, right? Hips. The big toe in the foot is very common to have osteoarthritis. When it comes to osteoarthritis of the hands, classically, osteoarthritis affects the joints closest to the nail. It can affect the joints in the middle of the fingers, but it usually doesn't affect the knuckles. And when we see osteoarthritis affecting the knuckles, we have to look for other diseases, specifically metabolic diseases like hemochromatosis, just to make sure that there's no other issues causing osteoarthritis of the knuckles. It generally does not affect the wrist. Unless there's any previous trauma, damage, surgery, it generally does not affect the elbow. It can affect the shoulder, but less common. but mostly it's the hips and the knees. And it generally doesn't affect the ankles unless there's previous damage. So those are different patterns that we look for in terms of differentiating rheumatoid arthritis versus osteoarthritis. Now, if you get into more specifics to the nitty-gritties, there are certain types of inflammatory arthritis that can affect similar joints as osteoarthritis, but those are much more specific situations. And that's why we really have to look for other ancillary causes and symptoms to try and build up a case to see whether this patient has inflammatory arthritis or osteoarthritis. Okay. And what complicates this even further is that in some patients with osteoarthritis, they can have what's called inflammatory osteoarthritis, where their osteoarthritis is so severe, it does cause a little bit of inflammation. But this type of inflammation is a different type than the rheumatoid arthritis and the pure inflammatory arthritis that we'll deal with as rheumatologists, and it doesn't respond to the same medications. The pattern and the joints affected in this case is still the same as osteoarthritis, but there may be a slight inflammatory component.
So can osteoarthritis then lead to inflammatory arthritis or?
Generally not. It does not lead to the type of inflammatory arthritis that we deal with as rheumatologists. It does not cause rheumatoid arthritis or other types of autoimmune inflammatory arthritis. But a lot of people get confused because you can have both.
Mm-hmm. You
can have osteoarthritis and you can have rheumatoid arthritis.
And as you were saying, if there was a previous traumatic injury, so, in the military, a lot of frontline troops, they have hand injuries or they're always exposed to the cold. I don't know if that leads to arthritis or not, or backs and that kind of thing. That would lead to OA. Does the same happen with inflammatory arthritis as well, too? If there's an injury, are you more prone to receive inflammatory arthritis, or is that still tied to more of an autoimmune issue?
It's still tied to more of an autoimmune issue. That being said, people who have a specific genetic risk factor, a specific genetic predisposition that would increase their risk of getting rheumatoid arthritis or inflammatory arthritis, sometimes it can be stimulated by maybe a viral infection, giving birth. Even sometimes vaccines can cause a flare of their rheumatoid arthritis, but it's short term. But generally, when that happens, we understand that these patients do have a genetic risk factor that makes them more likely to develop rheumatoid arthritis. And then it's just a specific trigger that triggers it. So in general, trauma doesn't cause rheumatoid arthritis. In people who have rheumatoid or in people who are already at high risk for rheumatoid, sometimes they tell me that their joint swelling started after an injury. And so, in those cases, we usually say it's not specifically caused by the injury itself, but the injury perhaps triggered activation of their rheumatoid, which they probably had before, or they had risk factors for it before.
That's interesting because, I've had dislocated fingers and that kind of thing too, and the knuckle's bigger than it used to be. So that's more of that would be more of an OA thing versus being an inflammatory.
100%, yeah. So when you have joint dislocations, when you have fractures, especially fractures that involve a joint, for example, the wrist joint or the knee joint, you're much more likely to develop osteoarthritis in that area. And with the osteo, you can have bony enlargement and it looks bigger like a walnut and it becomes harder.
Oh, something to look forward to then, I guess, to deal with it. With all the, so what you've talked about all the different types of inflammatory arthritis. Was there, we talked about rheumatoid arthritis. Is there anything else that you wanted to add about the other ones or that people should know or understand?
I don't want to make it too complicated because at a certain point, I would encourage people to, if they are concerned, to talk to their family doctor and to get assessed by a specialist because we can get into really complicated situations. But just in a general overview, in addition to rheumatoid arthritis, other types of inflammatory arthritis that's autoimmune in origin involve something called a psoriatic arthritis, which really occurs in people who have psoriasis, and it can actually occur in people before they develop psoriasis. And psoriatic arthritis has very similar presentation as rheumatoid. They have inflamed joints. And by that, what I mean is they usually have joints that are swollen, like a grape, fluid swelling in the joint, a lot of stiffness in the morning that can last 1, 2, even 3 hours. They can wake up at night because of the stiffness, and it usually gets better with activity. Okay. For psoriatic arthritis, it can affect in joints that are usually affected by osteo as well. It can affect the joints close to the nail of the finger. But it usually is asymmetrical. So the joints affected on one side of the body may not be the same joints affected on the other side of the body. So it's an asymmetrical kind of presentation. And a lot of times in those presentations, we also see other signs as well. We see perhaps an entire finger or an entire toe swell up like a big sausage, and you'll see it. It's like a sausage finger or a sausage toe. These patients can also have inflammation of the tendons. So inflammation of the heel, Achilles tendon inflammation of the plantar fascia, so plantar fasciitis. They can also have patellar tendonitis, inflammation of the patella. And so this disease can also affect the tendons as well. And when we look at these patients, because it's a systemic autoimmune disease, similar to rheumatoid, it can affect other organ systems. So if psoriatic arthritis, it can also sometimes cause inflammation of the eyes. It can be associated with inflammation of the bowel as well as psoriasis. So that's another type of inflammatory arthritis that we deal with. Another more common type of inflammatory arthritis that we deal with that I want people to know about is something called ankylosing spondylitis. I'm not sure if you've heard about this before.
No.
It's basically an autoimmune inflammatory disease that affects the sacroiliac joints and can move up the lower back. And usually it's basically inflammation of the sacroiliac joints in the lower back. There's a genetic predominance. Usually people are positive for a gene called HLA-B27. It tends to affect. Previously, we thought that it tends to affect males more, but with new research and better investigations and better imaging, we now realize it also affects females, but in a different way. This disease generally starts affecting people in their late teens, 20s, 30s. Before the age of 40, they start to have this. But it's always delayed in diagnosis because not a lot of people know about it. And so the average delay to diagnosis is still around 10 years. And so a lot of people are 10 years because a lot of the symptom that these people have, they chalk up to just regular stiffness. They chalk up to just regular, pulled muscle, and they never get it investigated. And so the key points of this disease called ankylosing spondylitis is that people tend to feel, even in their late teens, 16, 17, 18, or in their 20s, they start feeling stiffness in the lower back and the buttock area where the sacroiliac joints are. They feel stiffness in a similar way to the stiffness you feel with rheumatoid arthritis and other inflammatory arthritis, where they get up in the morning and they have a lot of stiffness in the back, lower back and buttock area. It takes them an hour, 2 hours to 3 hours to get moving to feel better. At nighttime, because they're laying flat and they're not moving, they usually wake up around 2, 3 a.m. because of the stiffness, not because of anything else, but the stiffness. They get up, they have to move around for about 30 minutes to an hour before they feel looser and they go back to sleep. It responds quite well to anti-inflammatory medications like Advil or Aleve. So some people just take Advil or Aleve over the counter regularly. Okay. And a lot of times that's the only symptom you have. This disease is similar to psoriatic arthritis, where it can also affect inflammation of the eyes. It can also cause inflammation of the bowel. Sometimes you can also get psoriasis with this disease as well. But most of the people initially will just have this back stiffness. And so that's why it gets missed. And that's why they don't really get it checked out, especially when they're young and they feel like, oh yeah, I'm still able to move, I'm still able to be mobile. Mm-hmm. And so they never realize that this is actually an inflammatory disease. And a lot of times when I see patients who've had this for most of their life, I see them in their 40s or in their late 30s or early 40s or even 50s. And I ask them, oh, do you have any back pain? They say, no, I don't have any back pain, because they've lived with this for so long that to them it's normal, right? The difficulty in diagnosing some of these inflammatory arthritis diseases, especially this inflammatory back disease called ankylosing spondylitis, is that previously, when we looked at imaging of the back, we only had X-ray. And so we were only diagnosing people where there's changes on X-ray because that's how we confirm that this disease is present. And what we discovered is, and so previously we thought that was how we diagnosed the disease. With the advent of CT scans and especially MRI, we're able to look at inflammation in the lower back in a lot more detail a lot earlier before the bony changes occur, before the bony damage occurs. And so we're able to start looking at people with this kind of symptoms, and we've discovered that there's this whole population of people where they do have inflammation of the lower back and the sacroiliac joints, but they never develop the bony changes that we see on X-ray, so they were always missed in the diagnosis. So that's why in the last 20 years, we've been doing research and we found out that there's this huge subset of people where they never develop X-ray changes, but they actually have the disease. And when we treat them, they respond just as well as those with the X-ray changes. Okay.
That's interesting.
Yeah. And so why is this important for us as rheumatologists? Is because a lot of these people have been misdiagnosed as chronic pain, when in actuality, they have this underlying inflammatory disease, whether it's rheumatoid arthritis, whether it's psoriatic arthritis, whether it's ankylosing spondylitis. And working at the pain clinic over the last 10 years, I've actually found a number of people who were misdiagnosed as chronic pain, but actually has rheumatoid, actually has psoriatic arthritis, actually has ankylosing spondylitis. And when we treat them for these diseases, it doesn't take away their pain completely, but it does bring their pain down by a substantial degree.
So a better quality of life then.
Better quality of life, and long-term uncontrolled inflammation, it can actually cause further joint damage that could be irreversible unless we catch it early.
And so when you talk about some of the treatments, and I know there's probably too many to just discuss in the short time that we have, but what are some of the, I guess treatments are targeting the inflammation really in a sense, right? For those joints.
Yes.
So what are some of those treatments that people would be expecting?
It really depends on the type of arthritis that they have. But in general, a lot of the treatments really center around adjustment and augmentation of the immune system. So for diseases like rheumatoid arthritis and psoriatic arthritis, we usually start with immunosuppressive medications. Okay, some of them are oral, some of them are injection. And about 20 years ago, there was a revolution in the rheumatology field where they came out with biologic therapy, which are stronger immunosuppressive therapy that are specifically targeted to specific cytokines in the body that's causing this type of severe inflammation. And we've had tremendous success. Back 20 years ago, there was no good treatment. Over 20 years ago, there was no good treatment for rheumatoid arthritis or psoriatic arthritis or ankylosing spondylitis. Whereas now, it is not uncommon for people to have complete control of their disease, no progression, no inflammation. And in many cases, we've now started talking about how we can treat people with rheumatoid arthritis really abruptly, suppress their inflammation, and over time, get them off medications completely. So that's the goal. So initially, a lot of these medications are immunosuppressive medications. But then we have many different layers of immunosuppressive medication, and there are many different kinds. And we use a combination of them to control patients' inflammation and control their joint disease. And we've been very successful.
Now, is there a natural way with nutrition or that, or is this not possible with this type of inflammatory arthritis?
That's a very, very good question. And it's something that's really blown up in research recently. As it stands, there are no specific nutritional recommendations. I tend to ask people to eat a healthy diet. I use a website called Dr. Wells Anti-Inflammatory Diet. You can search it online. And that has some very good advice. There has been some recent research on supplements and diet to see if it helps with this type of inflammatory arthritis. There does seem to be some benefit, but diet and supplements by itself is not enough to control the inflammation. In some cases, the amount of supplements that you have to take to treat your inflammation is just unattainable. And the volume you have to take, for example, some people say turmeric, curcumin can help with inflammation. Technically it can, but the amount that you have to take is just is just too high, and it's just not efficient, and it's not enough to control. In some of these cases, for example, in psoriatic arthritis only, weight loss is helpful. And interestingly enough, weight loss is helpful for osteoarthritis, not just because of the weight decrease, but it seems that the fat cells actually produce a certain type of cytokines that can cause increased osteoarthritis. So weight loss can be helpful in osteoarthritis, and weight loss is helpful in psoriatic arthritis.
So the medications are used, and then hopefully the individual can come off them at some point, or I guess they may stay on them for the rest of their life, depending on their case.
Depending on the case, yes. In many cases now for rheumatoid arthritis, I have a substantial percentage of people that are able to either come off of their medications completely after being under control for a couple of years, or they decrease to almost minimal medications. And that's been very successful. In psoriatic arthritis and ankylosing spondylitis, we haven't reached that point yet. But these patients can be extremely well controlled, where their lifestyle, quality of life, their functional ability is the same as a person without this disease.
Yeah, I guess it's tough because medications themselves have their own side effects, but I guess if it helps, then that's what's important.
Mm-hmm. I think it's important for patients to understand that the reason why we have to be aggressive in treating this type of autoimmune inflammatory arthritis that are severe, like rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis, is that not only does the inflammation cause joint damage that's irreversible, but interestingly enough, when your inflammation is really high, it actually suppresses your immune system. It actually makes you more likely to get infections. It actually increases your risk of heart disease. It increases your risk of blood clots. It increases your risk of stroke. And it actually increases your risk of cancer. And if we actually treat this type of high-level inflammation, those kind of risk factors and risks do decrease. And that's one of the reasons why, rheumatologists are very aggressive in asking patients to take these medications and try to suppress inflammation as fast as possible in these specific cases.
And that's probably another podcast in itself, just talking about the types of inflammation and the effects it has on one's health, metabolic health. And
yeah, definitely.
Yeah. Well, we've run out of time on this one, and I could still be talking, Max, because I find it very interesting. So thank you so much for coming back on the show, and hopefully this will be helpful for our audience.
Thank you, Tom. My pleasure.
And for feedback about the show or more information on chronic pain, you can visit our website, veteranschronicpain.ca, or follow us on Facebook and X on Chronic Pain COE, and on Instagram at chronicpain_COE. As I said, this is our last show, our last episode of Season 5, and we'll be starting Season 6, which will have a lot of great topics. So subscribe and tune in. And for our audience, stay safe and keep the hope alive.
The Most Painful Podcast
is produced for the Chronic Pain Center of Excellence by Story Studio Network.